Everyone. So renal transplant acute rejection management. Any deterioration, acute deterioration in allograft function associated with specific changes on pathology. Types will be hyperacute, acute and chronic. Though due to potent immunosuppressive drugs, the incidence has reduced from around 17% in living donors and 20% in deceased donor being affected with at least one episode of acute rejection in their post-transplant lifespan, which when compared to 1980s, it was around 50 to 60% one acute rejection episode. What are the risk factors? So pre-sensitization, having DSA, donor-specific antibodies being positive, high panel reactive antibodies, HLA mismatch, blood group incompatibility, prolonged cold ischemia time during surgery and delayed graft function. So when to suspect acute rejection? Any new increase in serum creatinine from baseline, and if there is risk factors were present, then any incremental increase in serum creatinine, worsening hypertension or proteinuria. So what do? We do first is ultrasound, which is being done non-invasive. There will be increased graft size, loss of corticomedullary junctions, prominent hypoechoic pyramids, decreased echogenicity of renal sinus, increased RI values of vessels. Though these are non-specific, but still indicate towards rejection. How do we confirm it? With a renal allograft biopsy. Biopsy not only grades the severity of the rejection, it also differentiates between T cell mediated and ABMR. It also determines the irreversible damage which has already happened in the kidney, that is IFTA, interstitial fibrosis and tubular atrophy. Few non-specific difference between ABMR and ACR acute T cell rejections is DSA will be positive in ABMR. There will be tubulitis on biopsy in acute T cell rejections. Neutrophils, polymorphs and glomerular in peritubular capillaries will be present in ABMR. CD4 staining is specific for ABMR. Now, NAF has categorized as per diagnostic criteria on biopsy as normal biopsy. Category 2 is antibody mediated changes. Category 3 is acute T cell suspicion, borderline. Then acute T cell being diagnosed in category 4. If those are chronic changes in category 5. And category 6 is graft is deteriorating, but we can't find the cause in acute or chronic rejections. As per the severity of acute T cell rejections, it's been grade 1 being less severe to grade 3 being the most severe as on the biopsy. So interstitial inflammations, if it's more than 25%, then in category 1B is tubulitis starts. In category 2, arthritis starts, in which mild to moderate arthritis in intima. In type 2B is severe intimal arthritis, and type 3 is transmural arthritis or arterial fibrinoid changes starts in it. Similarly, NAF has also given ABMR criteria, in which criteria group 1 is antibody mediated rejection activity is present, in which glomularitis score is more than 0 in category 1. In criteria 2, antibody interaction with tissue has been present, that is CD4 more than 1 on IHC or MVI more than 1. Similarly, criteria 3 and criteria 4, criteria 3 is DSA being positive, criteria 4 is chronic ABMR changes is being there. What is the limitation for currently used biomarker? Renal biopsy, there is false negative rate, and also pathologists vary as per their interpretations. Serum creatinine is not specific, not sensitive. Proteinuria is also non-specific. DSA in ABMR, its sensitivity and specificity high, but positive predictive value is only 35%. There are few non-invasive biomarkers, but our management doesn't change much. It's still heavily relied on the biopsy, which is alloreactive memory T cells, interferon gamma, ellipsot test. There is K-sort, which is expression of quantitative PCR of mRNA, expressions of 17 genes. There is donor-derived DNA, cell-free DNA, which is released from injured allograft in the bloodstream of the recipient. There are few urinary biomarkers, urinary messenger mRNA, microRNAs and microproteins. How do we treat acute T cell mediated rejection? So already NAF has given the grading. So as per grade on the biopsy, we'll treat it. Grade 1A will give pulse methylprednisolone, which is divided into over 5 days, 3 to 5 mg per kg. Maximum dose daily can around 500 mg. In grade 1B, again we'll starting with methylprednisolone, but if response is not there, an R-ATG, that is antithymocyte globulin, is being started from 1.5 to 3 mg per kg per dose, which is given for 1 to 3 days, hoping that decrease in creatinine or response of rejection from these medications will be seen. In graph grade 2 and grade 3, dose is 1.5 mg per kg to 2 mg per kg daily for 3 to 5 days. If it's still not being giving a suitable response, for 5 to 7 days ATG can be given. Total maximum dose people have given is up to 9 mg per kg. So while giving immunosuppressive drugs, few antimicrobials and few prophylaxis has to be started, like for CMV, PCP. So valganciclovir is for CMV, which we start, cotrimoxazole for PCP, then which is single strength Septran, then drops for oral candidiasis. Though fluconazole antifungal is not given in renal transplant, but few centers have started giving fluconazole also as prophylaxis. This is the treatment. We did the biopsy. We check for concomitant ABMR also if it's going in the kidney allograft. If it's not, then treat as per BNAV grading. The treatment of ABMR is the 4 main things which we have is pulse methylprednisolone, plasmapheresis, IVIG and rituximab. There are few experimental treatments also if it's not responding to these. Algorithm is very simple. Biopsy is done. If there is no concomitant T cell rejection, we see if the transplant is done, if it's acute rejection ABMR, then plasmapheresis is having a value in which we'll treat the patient with plasmapheresis with IVIG. If it's with glucocorticoids already been given. If it's responding, then this continues for 6 sessions of plasmapheresis. In 6 sessions, it's been said that after 6 sessions, all the antibodies which are supposed to be cleared with this mechanism is already done. Rituximab, and after having a good response, then augmented maintenance immunosuppression is to be continued. What is successful reversal of ABMR? Decrease in serum creatinine, decrease in proteinuria, decrease in DSA, immunodominant DSAs, which were present in the recipient. Then resolution of changes on repeat renal biopsy. There are few second-line treatment like bortezomib, which is a reversible proteasome inhibitors, eculizumab, which is a monoclonal antibody directed against C5 fragments. This is a salvage treatment for refractory active ABMR. It is not shown any effectiveness against CD4 negative ABMR. There is few experimental therapies like C1 inhibitors. It's been used against placebo. It has been seen over a 2 weeks duration. There was no significant improvement as compared to plasmapheresis and IVIG. There is something called as mixed acute rejection, in which there is concomitant, if it's ABMR we are suspecting and biopsy shows concomitant T cell rejection. This is being treated with plasmapheresis with IVIG alternating with RATG. We do it alternate days. Plasmapheresis is alternate day because it removes endoluminal antibodies. It doesn't remove the interstitial antibodies. So we give 1 day for the interstitial antibodies to come in the vascular system, and plasmapheresis can remove it. That's
clear. Do we have any data of ILBS?
Yes, so I have data from November till now. So we have done around 18 transplant, barring the 2 which is in the ICU for discharge. So out of that, 1 had acute ABMR, which was ABO compatible transplant from donor being her own son, which was treated with plasmapheresis. Right now her creatinine is 0.8. 6 sessions of plasma. 1 T cell mediated rejection in disease donor kidney transplant which we had. His creatinine is around 1.3. It was extended donor from the cadaver, so 1.3 is fine for